So with the beginning of all of our meetings, we'll start out by saying the mission statement together. We, the Stonehill Franciscan Services community, in the spirit of St. Francis of Assisi, offer a continuum of quality lifetime care services in a dignified atmosphere. So I wanted to share a quick video with you guys that I found the other day. It's from a hospital affiliated group, but looking at our overarching goals of customer service and employee retention and resident satisfaction, this video I think kind of highlights a lot of the work that we do, and it really touches on the importance of that relationship with families and residents. So, just something to kind of get us started.
This is why I use Grammarly to check my work.
If I'm putting commas, that's okay.
She's in palliative care for it. Still called the facility. Got some ID access going.
There's nothing left to say. There's just a perfect day for us to use. There's nothing else to see. No better place to be. Now that you're with me, and I'm with you. Why don't we wait here? I just wanna stay here.
I saw a patient this morning with that name.
Why don't we wait
started to suicide.
here? Now,
Bed management, Michelle speaking. Okay. What's the patient's name? McIntyre. All right, that's a compassionate bed. Let me see what I can do.
You guys need help? Follow this hallway down there. Follow the signs to Robin's.
so please don't move an inch. Don't ever change a thing. Just let me take this in and hold it tight. Why don't we wait here? Now,
We grew up together
why don't we wait?
and Lou and I together.
I just wanna stay here. Why don't we wait here? Now,
I should say Stonehill Care Center. But you can see that, that relationship piece that we have with our residents and families, it really does make a difference, especially, on so many different levels. So it's all the extra little things that we do every day that really mean a lot to people. And I know that those things go on all the time, and we probably don't always touch on all those things. So it's just important to kind of keep thinking about those little things and how can we make someone's experience at Stonehill better. So just a few housekeeping things. Be sure that if you haven't signed in on the sign-in sheets that you do that. I think the sign-in sheet's up by me now, so if you haven't had a chance to do that, please sign in. Make sure that you're clocked in for the meeting. If you haven't clocked in, let me know that after the meeting and I'll make sure that you're clocked in. Healthcare Academy Q1 assignments are due March 31st. They've all been assigned, so if you haven't had an opportunity yet, please go in and start working on those. And a couple changes that, one change that we made since our last meeting in September, we did place gate belts in all the resident rooms to make it more convenient for staff. Nurses, CNAs, people that maybe forgot a gate belt or another resident's using one of their gate belts. It's just kind of an extra feature to make the job a little bit easier. Medication cards, I guess there's been some areas that have had more difficulty getting the cards labeled when they start them. So just a reminder that if you're starting a medication card, please make sure that you label it with the date. So kind of getting back to the video, I wanted to touch a little bit on the nursing department expectations. Really looking at the environment, making it a culture of one that everyone wants to participate and be involved with. It's important that we demonstrate professionalism when we're here, to each other, to the residents, to the families. So that means keeping your personal items like cell phones and things like that in your locker. I've heard that there's been different times in different areas where this continues to be an issue. It just makes everybody look bad. It makes everybody look unprofessional. It makes it look like our focus isn't the residents and what we're doing here. Also following dress code policies, wearing your name badge so people know who you are, what your role is, just simple things. Having good communication with your team when you observe something that we could have approached differently or did better. So if you see something that maybe isn't up to the standard that the rest of us would have, it's important to bring that to the person's attention in a professional way so that they know what the expectation is going forward. And always promoting excellent customer service, so being respectful to each other, to the residents, and to visitors that come into the building. So we passed around an update to the fire safety plan. I wanted to kind of read through that with everybody, and I'll just highlight the nursing department roles. So we made some changes just to make the fire plan a little bit more solid with how we respond and more clear on who is doing what during a fire. So to start with, we would always follow RACE and PASS. RACE stands for Rescue, Alarm, Confine, and Extinguish, and Evacuate. So if you observe a fire, the first thing that you'll want to do is rescue anyone that's in the immediate area, remove them from danger. If the fire alarm hasn't been triggered, you'll want to pull the alarm. You'll want to try to confine the fire to whatever area the fire's in, and then you'll want to try to extinguish it if you're able to, and then continue to evacuate. If you do attempt to extinguish a fire, you'll want to follow PASS, which stands for Pull, Aim, Squeeze, and Sweep. Some of these things might be a little redundant because they haven't changed, but it's always good to review that, especially when you get in an emergency situation. Sometimes those things don't always come to mind. So following the fire plan, we would remove residents, visitors, and staff from immediate danger to the safe side of the nearest fire door. Close the fire door to the room or the area. Pull the fire handle if it hasn't already been alarmed. We would announce over the public announcement system, either the phones or the overhead, that there is a fire emergency, and then the location. We would close all doors to the immediate area, evacuate the remaining residents, visitors, clients, and staff from the fire area to the safe side of the nearest fire door. We'd want to make sure that we kept hallways free of equipment and things like that so that there was a good flow for traffic. If the fire is in an area where there is no fire or a wall between adjoining rooms, you want to remove anyone in the adjoining room first. Remove occupants in the rooms across the hall next. Remove all other occupants in the general area of the fire away from the fire. You would place the resident magnet on the lower side of the door frame on the knob side. The incident command team would be initiated. So then we would continue to evacuate. As time allows, verbally notify incident command and reception. What is the situation? What is being done? What are the problems? Who and what is needed? Who is the person in charge to contact? And then we would fight the fire as conditions allow. And we would follow pass. You would follow your escape route. And then getting into the departmental responsibilities, I'll touch on the health supervisor responsibilities, then charge nurse, then the CNA and CMA service tech. So a nurse manager would confirm with charge nurse the affected area by fire, contact the incident command or command chief. They would become the command chief. They would look at what is the situation, what is being done, what are the problems, who and what is needed, who is the person in charge to contact, which typically would be me or Peggy. Physically report to the Stonehill conference room or alternate emergency site using the stairwells. After hours, designate a staff member to assume responsibilities, notify the entire facility using the PA and the phone system. Use the elevator key to lock elevator A, B, and C, first floor. Dial 911 to verbally confirm the presence of a fire. Provide the fire department the details. Designate a staff member to call incident command team members. And those numbers are located in the red binder in the conference room on first floor. If ground floor is affected, environmental services and dining services would designate 2 staff members to check the severity of the situation. So they would send staff members to the fire location. Remove baseline accountability status reports from the nursing stations and other departments. Meet the fire department personnel and provide incident details. Once the fire is all clear, report to the facilities director, which is Dan Cruiser. Charge nurse responsibilities, retrieve the fire drill report and accountability. Designate staff members to watch the exit doors, the stairwells. In area affected, initiate horizontal evacuation as necessary beyond the fire doors. If not in affected area, designate 1 staff member to bring fire extinguisher to the affected area and to assist area with evacuations. So that's a change from the previous policy. So on each floor, the charge nurse would send somebody from their floor to the area where the fire is to help with evacuation. So we'd have more people to help if there was actually a fire emergency. Does that make sense to everybody? That's probably the biggest change. CNA, CMA, and service techs. In affected area, follow race, rescue alarm, confine, and evacuate and extinguish. Throughout the facility, close all windows. Evacuate the fire area occupants as necessary beyond the fire doors. Check all areas of the room, bathroom, closet, floor. Close resident room door to indicate the room is vacant and place the fire magnet on the door frame. Assist with resident accountability and report the accountability to the charge nurse. Move all dietary carts to the window wall of the dining room's core areas. Move all laundry carts to the end lounge areas opposite of the stairwells. These areas are not accessible. Move them away from the flow of traffic. As directed by the nursing supervisor, assist with fire extinguishing activities as appropriate. Refer to the policy regarding the fire extinguisher line. In affected areas, you will be directed by the charge nurse to perform one of these duties. Perform resident accountability for the unit using the fire accountability form. Remember, it's not necessary to close doors and apply fire magnets. So that would be if the area is not affected. Observe emergency locked doors near stairwell, so we'd be watching the exits. report to the affected area with fire extinguisher to aid and assist unit following race. Does anyone have any questions about those? So the charge nurse would be assigning the CNAs or med aides, service techs, those responsibilities. All right. Well, if you think of questions or have any thoughts on the updated procedure, just let me know. So the next thing we wanted to talk a little bit about was the resident care guides. I know we talked about them back in September at our last meeting. We started a pilot on 3 North where they started using a more formatted cheat sheet, is what we used to call them. It had specific information like the resident's room, if they wear heel protectors, how they transfer, what their bath days are, things like that. I've heard mixed thoughts on that. It sounds like some people like the new model and some people, it actually was passed on that there's 2 sheets being used now, the old sheet and the new sheet. So does anyone have any thoughts on a more consistent care guide? I know Skilled is working on developing one for the skilled areas. We haven't rolled it out to all the areas yet because we're still trying to make sure that everything that's on the form is what we want to use.
I just saw the one upstairs, the, on first floor still, that's the first one I saw. We still have our 2 downstairs.
Okay. So the ones that we're working on for Skilled, they would still have the same information as the ones upstairs. I think they're formatted a little bit different so that there's more room to write because there's more changes and things like that than upstairs. But they would be a similar format as far as the
And I'm
information.
working on the 1 South today, and then I'll do lower level next. Cause I just did first skilled yesterday.
Yeah, it's not bad. It's a good one. She did good on it. It has like the
It's
information
it's
that
the-
you need.
It's the same as 3 North, it's just in a different spot, kind of.
The reason we want to switch them to be more uniform is so that when people float or when things change with the resident, people know where to look. It'd be ideal if we could print a report out of Matrix that would have all that information, so we wouldn't have to try to keep something up to speed on everything. But unfortunately, that's not where we're at yet with Matrix. But until then, I think this is a
Ideally,
workaround.
do you have to have the doctor's appointments on that sheet? Like downstairs, there's the nurse and then ours. And I don't need to know, like, I usually find out from the nurses if there's an appointment,
Mhm.
I don't know,
They're very busy downstairs, the cheat sheets.
Maryland's is.
Yeah, Marilyn
Very,
is so
it's
crazy.
very, there's not even no room to write on it.
Okay.
But she has her way, and it's like, I know we're all supposed to go to, 1, but for doctor's appointments, I wouldn't really think you would need that on there unless, I don't know, that's
It's
just
that
me.
day. Right.
I mean, I usually ask if there's,
How do you think they're going on 3 North, Sammy?
They're okay. I mean, I think like the CNAs don't need, because we have like if they're ICF or skilled on there, and I've had CNAs come up and say, what's ICF? What does that mean? Like,
Mm-hmm.
they don't need to know necessarily that stuff, or
oh,
they're,
yeah, they do.
they're,
Yeah, they do. They need to know.
They
who's
need to know
ICF
if they're
and
skilled or-
State asks them that.
oh yeah, we
Yeah.
hardly ever have a skilled person when something's up on our floor, so.
I think
And it's on
that's
our board.
important because
Yeah, and I think that's where, looking at the long-term care units and then the skilled units, I think that there's some different aspects of care that people are looking at. But I think once we finalize the material that's on them, I really want the entire building to have them and be consistent with how we use them so that people aren't looking in all different places for information.
That would be nice for people that like float everywhere.
Yeah,
It's like some stations
Especially
are
in the
great and
full
other
board.
stations it's like
Yeah.
a free for all, you have no idea.
right. And that's not, that doesn't make for a good experience for the employee, for the residents, or,
Yeah,
people are
like, cause
just,
you go in and you're like, hey,
yeah.
and they're like,
Yeah, so I think it would just help with the flow for everybody, just if once we move to having these more established, but more information will come, because I think, we started it in some areas and we're slowly working on what needs to be on there versus what doesn't need to be on there. And once we have that finalized, you know, we can always change things too after we get started if we find that they're not exactly how we want them to be. But I just wanted to kind of revisit that because I know we talked about it in September and it's been some time. So, you know, we're getting to the point where it's gonna be implemented throughout the building, so. And if anyone has any other thoughts on that too, let us know. We did get new Stonehill mugs. I know that for a while we ran out of cups or we were using all kinds of different cups, but these are the new cups that we will use for residents. In the post-acute areas, we will send them home with residents. I know that was a question that some people had. But they are dishwasher safe. They all have a lid. You can use straws or you can use them without straws. They're more insulated, so hopefully they keep, you know, drinks and water cool for a longer period of time. This pertains to catheters. So the CDC guidelines changed for how often we change an indwelling catheter for a resident. We used to have orders to change them every month and as needed. The CDC now says that changing indwelling catheters for drain bags at routine fixed intervals is not recommended. So it kind of makes sense as far as reintroducing bacteria and things like that. So we went through everybody that does have a catheter currently, and we got rid of their orders to change them monthly to just changing them PRN. So we would change them if they're clinically indicated, like if the resident had an infection or signs and symptoms of infection, if they had an obstruction, or if the system became compromised. So we're not going to be changing them as frequently as we had been. So when CNAs are doing cath cares or if nurses are assessing, we can change them when it's clinically indicated, but it would only be changed for those reasons. Any questions about that? Catheter supplies are now located in room 167 in the closet in 1 East. It used to be the tub room, spa room. Isolation precautions. I just wanted to remind everybody that the infection control resource manual is on the intranet under nursing and infection control. We moved the isolation supplies also to room 167, which is the spa room on 1 East. And that's hopefully temporary, because I know that with the scale, they told me that it's hard to get people in and out of that room. And then looking at people that are on isolation, the care plan should indicate what type of isolation precautions a resident has. Rachel Cruiser has been updating the care plans to include that information, so if anyone's wanting to know what type of isolation someone's on, it would be on their care plan. It should also be on the huddle board on the unit so that when staff are getting report and looking at what's going on with people, that information would be on there so that they would know what type of isolation precautions to follow. The resident room for isolation residents should have a stop sign posted for visitors and staff to kind of alert them that this person's on isolation so that they can get additional information as to what type of PPE to apply. With all residents that we would encounter, we would always do standard precautions, which means that we would clean our hands before we enter and before we leave a room. Cover our mouth, nose with our arm or a tissue if we're going to cough or sneeze. Gown and glove if we're planning to encounter some bodily fluids. Wear a mask and eye cover if you expect or anticipate that there might be bodily fluids that splash. For contact precautions, we would implement standard precautions like we just discussed. And really, we would be looking at gowning and gloving before we enter the resident's room, and we will be using dedicated equipment for the resident. So if they have disposable equipment like a stethoscope, if it's not disposable like the vitals machine, we would disinfect it before and after we leave the room. Droplet precautions, we would do standard precautions in addition to wearing a mask. Airborne precautions, we typically do not have this because we don't have a negative pressure room. But if a resident was needing airborne precautions, we would have to work with their physician to either find them a higher level of care or to see what we could do in-house to keep them here. So another change that we had, looking at readmissions and just workflow and making things more efficient for people, we worked with our medical directors and we now have standing admission orders for residents. So we used to have the confirmation of orders sheet that would say, you know, we have this new resident who's admitting to Stonehill. These are orders that we would like to have on board in the event that they have some type of a situation like a headache or, I don't know, just random things like can they have a flu shot and things like that. So these are all now standard orders that we have signed for everybody. So it should make it less cumbersome trying to get orders for people that are just coming in or waiting for that confirmation of orders sheet to come back. Right now, Michelle Dura is filling these out for new admissions and she's faxing them to the pharmacy so that they can enter the medication orders. That process will continue, but if you get an admission on a weekend or if Michelle's off, this form would be in the admission paperwork packet, and then you would just put the resident's name and fax it over to the pharmacy.
Question on that, Matt.
Yeah.
If these medications don't apply to the resident, can we just simply not initiate them? Like say melted magnesia for dialysis patients, or if somebody has an allergy to one of those few,
Yep.
we don't have to get a doctor's order to DC it, we can just not initiate it, correct?
Yeah, so we worded it so that if it's contraindicated,
Oh, okay.
then we wouldn't implement. Because you're right, there's,
No, I guess I didn't even see that part on there.
does anyone else have any questions on this? Hopefully it will help make things easier for everybody. And it should help with like readmissions and stuff too, because if you think about, a lot of times people are coming to us and sometimes they don't have all the orders that we would need, like therapy to evaluate them and things like that. So there could be a delay in the resident's care if we don't have these orders right away. So it's nice that we got them on board so that there's not time spent by the nurse trying to get them. There's not time wasted for the resident to receive care. And we're not bothering on-call after hours to be like, I need an order for Tylenol because they have a headache or they have pain and I have nothing to give them. So hopefully this will help.
Are you gonna add Imodium?
So that's a good question. We had it on there, but the medical directors wouldn't sign off on that because they said for residents that have C. diff and a diagnosis like that, they wanted us to work through their doctor to get that order. So there was a couple things that we had to tweak on here. That was one of them. I'm trying to think what else. We had to get creative with how we looked at like the TB, because like TB on the confirmation of orders it said you may administer step 2. But sometimes we had people that came in that didn't even have step 1 read, or maybe they had a chest x-ray, which would count as step 1. So we just worded it like, you know, we would follow our TB policy protocol for orders. Therapy communication, this went out in email like a week and a half ago, but anytime you get new orders for physical therapy, occupational therapy, or speech therapy, the nurses would fax that information over to Aegis instead of calling it or leaving it, or like sending an email, I guess. Katie said that she was getting all different kinds of notifications about therapy orders, and so this kind of makes it more of a consistent process so that something doesn't get lost in the shuffle. She said that it's been going much better.
So I actually have a question. So when we get a new admission, do we just assume she knows that
Yeah, good clarification. So new admissions, because we have those standing admission orders, we have PTOT and speech to eval on there. So for new admissions, you do not need to fax anything to
So she'll
therapy.
take care
It would just be those, like, long-term care residents getting picked up by Part B, or if someone was eligible for skilled and came back ICF, but then got orders for skilled, we would need to let them know that.
Are they gonna get the buttons on the fax machines fixed where they work? Because 11 doesn't work.
Oh, I didn't know that.
Well, at least on 3 South and 30 North. That's
Okay.
Working 3 South last night, and I couldn't get it to work. I got 3 North and 30 North.
Okay, I'll have Glenn take a look at it. Good to know. So then, another short little video that we'll look at watching. So October 1st of this year, the way that skilled nursing facilities, the methodology for payment has changed. So the way that we were traditionally paid, so if someone came in, and this pertains primarily to post-acute residents, so the people that are coming in skilled, we were paid based off of RUGs, which included therapy minutes, non-case mix therapy minutes, nursing care, and non-case mix. But really payment was primarily driven by therapy. So depending on how much therapy a resident participated in, that's how much reimbursement we received for their stay. So if someone received like 90 minutes of PT in a day and 90 minutes of OT in a day, we would be paid much higher than if they didn't receive that much therapy. The new model is called the patient-driven model, and it will look at therapy, so PT, OT, and speech separately. It will look at nursing care, non-therapy, ancillary, and non-case mix, so there's more components to it. But really what it's looking at is the diagnosis for the resident admitting to our facility. They're looking at, so if someone comes in, and let's say that this person is 76, they were in the hospital for pneumonia, and they needed to come in for rehab, but also some medical needs, because let's say they're diabetic, they're morbidly obese, and they have COPD. So all of those things will now factor into the way that we're paid, because obviously the more complex of an individual, the higher the reimbursement should be, because the more nursing care we're providing and things like that. So the video kind of explains it a little bit better than that. But this will be a big change.
I have so much to manage already. How am I going to prepare for all this change?
My patients rely on me. How am I going to adapt without compromising outcomes?
I've been through changes like this before. How hard can it be?
Change is coming. And with change, a lot of different questions and emotions are on the rise. Like confusion, anxiety, and indifference. Aegis Therapies is your resource to help guide you to success in PDPM. Let's start with the basics. PDPM is the new proposed Medicare reimbursement model for skilled nursing facilities. It takes effect on October 1st, 2019. Under PDPM, therapy minutes will no longer be the basis for payments. Instead, SNF payments will be based on specific resident characteristics, such as their diagnoses and functional levels as measured by Section GG of the MDS. The current RUG-4 model has two fundamental reimbursement components: therapy and nursing, plus base rate. PDPM has 5 fundamental reimbursement components: 3 therapy, 1 nursing, and 1 non-therapy ancillary, plus base rate. PDPM represents a shift in reimbursement away from paying for services performed to paying for patient characteristics and conditions. Now for the details. Section GG of the MDS will be used to provide the functional measures that will help to determine the case mix and apportion the per diem payment for PT, OT, and nursing. The MDS assessment schedule will be reduced to a 5-day MDS and a discharge assessment only. The interim payment assessment will be optional if there are changes in the patient's status. Group and concurrent treatments can now be provided, but they will be capped at 25% total. Variable per diem introduced for the PT-OT portion of rates, minus 2% reduction after day 20 for every additional 7 days of therapy. What's next, you ask? Start by taking an in-depth look at your facility and determine how you can maximize the accuracy of diagnostic and functional coding and measurement skills for nursing and therapy staff. Your success will depend on your ability to remain agile and effective without compromising patient outcomes. And remember, Aegis Therapies is here to support you through change as your PDPM resource.
Alright, so that's just kind of a high-level overview of how the payment will change for us. More information will come out closer to that date of October 1st, but I think I'm kind of excited about it because I think that it's important that when you're looking at all the care that goes into a resident's care plan, it's more than just therapy. I mean, nursing obviously drives a lot of their care, so I think that this will incorporate more importance on the nursing care versus just the therapy minutes. And it will really it'll help paint a better picture of the person. So if we have a more complex person, I think we should be paid more, you know, if we're providing a lot more care. So I think that it'll be a good shift, and it will really focus more on the individual person and how we can get them better than, you know, just trying to get as much therapy in as we can. So. But looking at the diagnosis, I think that it will be ever more important that we continue to get diagnoses for medications and treatments. I know that's kind of been an ongoing issue with doctors, but it really will affect reimbursement and payment because a lot of the payment will be driven off of their diagnoses. So. And another thing I wanted to quickly touch on, so we have been receiving information from QRP, which is Quality Reporting Program through CMS, the Centers for Medicare and Medicaid Services. And they're benchmarking facilities on how well they do with readmissions, with pressure injuries and falls with major injury. So those are things that we will continue to focus on, looking at doing a chart review for people that are readmitted to the hospital and looking for opportunities to figure out, you know, when people are having symptom changes or things start to develop for someone, how can we intervene and communicate with the physician to make sure that, you know, we're not sending someone over shortly after they admit to us. And that's kind of been an ongoing focus. I know we implemented those stop and watch tools, the SBAR, and some of those other pieces, but the change in condition will continue to be huge. Skin and looking at pressure ulcer prevention, pressure injury prevention is huge, and preventing falls with major injury. So, any questions about anything that we went through? I know a lot of it was review, and we touched on a couple new things, but.
Are you guys still thinking about the palliative and hospice downstairs or not?
Yeah, so kind of a little update on palliative care. We did join CAPC, the Centers for Advanced Palliative Care, something like that. And so through CAPC and through that subscription, we will continue to look at education and resources to kind of prepare everybody for that transition. We also applied for a grant to change the conference room or the therapy office space on ground to get couches and like a coffee bar and things for families to kind of have a decompression zone. So we're continuing to kind of get those things set up so that we can really have things in place before we really roll it out. But we haven't really communicated with the providers or the hospitals that we're moving forward with it, but we will continue to move things along as we get things set up. Because yeah, the census will continue to kind of bounce around like it has been, just with more people going home with home care and things like that. So we're trying to be a little bit more creative with services that we offer. Good question. Any other questions about anything in general? All right, good deal. Thank you all for coming. Have a good rest of the day.
Leave the chairs.
Oh yeah, leave the chairs. Thank you guys.